Good morning, everyone. I'm sure this will be the simplest talk of the day. Are we over-diagnosing osteoporosis? That is the provocative questions that we are asking. Indians have among the lowest fracture risk in the world despite having very low BMD. And there are no prospective studies in India to delineate the relationship between BMD and fracture risk. So most centers in India in this background use diagnose osteoporosis by comparing against the WHO standard of young Caucasian women. This is a potentially problematic situation due to racial differences in BMD, due to many factors such as peak bone mass acquisition. So we need to realize that T-scores are basically like relative numbers, just like NEET percentiles. It's not how good you are that matters, but how good you are compared to the next person. That is what matters. So who you compare yourself with is a very important thing when you calculate scores like T-scores. So that is why we have things like mean, SD, T-scores, things like that. When you check blood glucose, you don't compare yourself with the young person of your race. When you check cholesterol, you don't compare with a young person of your age. But when you check bone mineral density, you do that. And that leads to some problems. But you might think we have FRAX for this issue. Unfortunately, FRAX thresholds for assessment and treatment are not universal. FRAX is basically a risk score. It tells you this is the risk of fracture. But you and I might perceive risk differently. For example, I might drive at 40 kilometers per hour and be very happy with it. You may not be happy with that. This FRAX thresholds for assessment and treatment are dependent on fracture risk, mortality risk, cost of treatment, willingness to bear that cost, and a host of other factors that cannot be universal between US or UK and India. This lack of fracture dates at any given BMD and the heterogeneity in healthcare models makes FRAX cutoff that cannot be extrapolated to the Indian setting. So you might think you can use both, but it's a little more complicated than that, which is why we are making this presentation. So we ask this question: does using Indian normative data change the rates of diagnosis of osteoporosis? It's a retrospective study conducted between July 2016 to December 2017. Men and women aged 50 years or more who underwent DEXA scan were included. And we recalculated the T-scores based on Indian normative data published by ICMR with the following equation. And henceforth it will be referred to as the Indian T-score. So we used appropriate statistical methods. Disagreement was quantified using weighted kappa statistic, and agreement between Caucasian and Indian T-scores were assessed by Spearman correlation coefficient and a Bland-Altman plot. So here is the results. We studied 1,161 patients with a mean age of 61.4 years. Our cohort was slightly male predominant because of the differences in healthcare seeking behavior. Our BMI was mean BMI of around 26.3 and a head BMD of 0.874 and a spine BMD of 1.052. These were the T-scores when you use Caucasian data versus Indian normative values. So this is the effect of adoption of Indian normative values on T-scores. The hip T-score jumps from minus 1.34 to minus 0.75. This is mean T-score. And the spine T-score jumps from minus 1.24 to a massive 0.039. So you might think this could be driven by a few outliers, but even the distribution isn't very different between when you use hip T-scores in the Western population versus the Indian population. It's not due to just few outliers, and it holds true for both spine and hip. So what happens when the T-score changes? Does the classification change? You bet it changes. There's a huge amount of change in classification. The osteoporosis rates change from 25.9% when you use the Caucasian data, where it comes down to only 2.6% when you use the Indian data. There's a massive reclassification happening here. So this is the classification data when you take BMD at both sides, at least one side, hip or spine. So 25 to 2%. It reduces from 25 to 2%. And what is even more important here is that the graph on the right represents what happens when you use the Indian data, the normal or the predominant cohort here. Slightly less number of people are osteopenic and even less number of people are osteoporotic. That makes sense. When you use Western data, it shows that majority of the patients are either osteopenic or osteoporotic, which is a little difficult to accept even biologically. So this change in hip classification is true whether you use hip or spine. This is the hip. The effect is more marked in the spine, but it's also seen in the hip. So is there an agreement between ICMR and WHO data? Yes, there is an agreement, but it's nowhere near as severe as published before. The kappa value is 0.314. Now the kappa is a score of agreement. Basically it tells how much agreement is there over and above that can be expected by chance. And if there is a disagreement, what is the severity of disagreement? For example, if I say it is osteoporosis and you say it's osteopenia, that disagreement is mild. But if I say it's osteoporosis and you say it's normal, that is a severe disagreement. It accounts for that, and it is very, very modest. So there is a massive change in total osteoporosis classification from 25.9 to 2.6%. This is different from the data published by CMC Vellore. I will come to why it is happening. This is the seminal paper published by CMC Vellore. The authors are sitting in the back. See, this study had 2,976 subjects with 316 fracture subjects, 2,199 hospital patients, and 461 community data. Ours is predominantly community data. So we see that the shaded values in the kappa value of 0.82, which means that there is almost perfect agreement. Why would they say there is a perfect agreement? Because of these two graphs, the one on the left and the one on the right. So when we
your time is up.
When we compare the correlations between the CMC and our data, it is the same. When we compare Bland-Altman plots, it's almost the same. So why do we get this difference? The difference is that there were high-risk patients in CMC cohort. This reclassification is more likely to occur with values near cutoff values. So to understand this, look at the this thing. This reclassification is more likely to occur in the ends of the curve. So what population we select matters. Hip spine discrepancy is an important problem, and the agreement between continuous variables works only if they are used as continuous variables, not when you cut them as categorical variables. So our trends are large number of patients, and to conclude, adopting ICMR data will have a massive change in the way we diagnose osteoporosis, and we need to compare apples with apples and not apples with oranges. Thank you.
Okay. A good debate or oration rather than an oral presentation.
The patients that you selected were basically people who had a BMD in your institute, right?
Yes.
So this is not you're not seeking out in the community to do a study. So I think one of the things, when you reclassify them as normal osteopenic osteoporosis, when you order a BMD itself, there is a clinical suspicion that there is a problem.
No, these were actually there is something called health checkup data.
Yeah, so that's why you have more men than women. I was very surprised to see. Usually in a hospital setting, or when a clinician sees a patient, we will order DEXA for women more than men. Isn't it?
But I don't think that will make any significant difference to the outcome of the study, because we are comparing only numbers, not the risk factors. We are completely disregarding risk factors. With the set of numbers, we are applying one set of criteria versus another set of criteria. Purely numbers, nothing else. So I don't think that will make any difference to the outcomes.
But I think when you mentioned that the percentages of normal osteopenia, osteoporosis is more accurate with your classification than the other classification, I don't think you can make a valid statement, because people who have seeked healthcare behavior, people who have seeked healthcare, or people who have got a BMD, there is already a referral bias in terms of who is getting the BMD.
Yeah.
So when you look at that data, to say that maybe by doing the ICMR you're missing people with osteoporosis or osteopenia. So to say that the restratification actually works better is a hard.
No, I'm not saying it works better. It works differently, because the cohort that we use is more of an everyday cohort, not the high risk cohort of patients who have already fractured.
I don't think we have enough data on the cohort to comment on that very strongly.
I might have to disagree with that. Yeah. Okay.
Thank you.
Thank you.